So, live record. I think it is um, live stream. I think it is going live right now. I hope. Well, I'll figure it out if it doesn't go through. So I think we're recording. Anyway, so ready?
Ready, yeah?
All right. So, good evening, everyone. This is Dr. Famuyiwa again, and I have my favorite doctor scientist with me tonight. And this is Dr. Nadera Mansuria Tia. See, I'm getting better at pronouncing your name.
Yeah, I see that. Yeah.
I just need to practice it a few times. So, Dr. Masuria Tia is with Pregmune. You are the scientific director for Pregmune.
Yeah.
And I know Pregmune came about from the Braverman Institute and it's now Pregmune as we know it today. And I know they've done a lot of research. So I want to invite you tonight to just tell me a little bit about yourself, reintroduce yourself again, but give us a little bit of background. How long has Pregmune existed and how long has the Braverman Institute existed and what's the length of time of all the
Yeah.
wonderful research you guys are doing?
Hi, everyone. Thank you, Dr. Yemi, for having me here tonight. Very exciting. So I'm Dr. Mansuria Tia. I'm the CSO, the Chief Scientific Officer at Pregmune. Pregmune, as you may know, is the sister company of an IVF center based in New York called Braverman Reproductive Immunology. So I've been working as the scientific director at BRI, and I started with them back in 2014. And around 2020, we decided to create a sister company, and that's Pregmune. So we have been using all the data accumulated over the years from the BRI clinic to try to make sense of all the immune findings that we had accumulated over the years. As you know, BRI and Dr. Braverman has been quite a pioneer in the field of immune reproduction. At the time when I first joined, he was already screening systematically his patients through the pregnancy for different immune factors. And I joined to try to make sense of all the data and try to design reports that are more accessible to the patient, but also to the physician.
Excellent. Wonderful. So that's really fascinating. I'm really impressed with all the work that you guys have done and the fact that there's a continuum of care. So we over the past, I think we've had two other webinars now. The first one we introduced what reproductive immunology is, and we talked about patients who are having difficulty maintaining a pregnancy or patients who are having difficulty getting pregnant after having very good quality embryos placed in them and they just don't implant after up to 3 times. Now, good embryos, I mean, could be euploid embryo, meaning we already know that they're genetically normal, or high grade, high quality blastocysts that should be in a young patient that should be good anyway. So, so, um, so just to recap, so we talked about reproductive immunology, and then in the last um, webinar, we talked about the treatments that could be used. We didn't go over all the treatments though, so we went over prednisone usage and things like that. So tonight we are going to look at specifically two other factors. The third one I put in there for inclusion, and we'll talk about that a little briefly when we're done. Correct?
Yeah.
Yeah. All right. So I know that when we send patients for testing, you give us a report back and you give us recommendations. And now we're going to say, okay, we're going to start this patient on a treatment. A, the treatment strategy, and B, how do you monitor response anyway, right? So the first treatment we're going to look at is metformin. Um, why would you recommend metformin, and what is metformin? What would it do?
Yeah, so as you may know, metformin is a common drug used for type 2 diabetes. So
Correct.
the main
Yes.
goal is really to reduce your glucose level and improve your insulin sensitivity. Metformin is mainly used to try to improve the quality of your egg. And of course, better egg means potentially better embryo
Yeah.
quality, better embryo development,
Mhm.
and increase a chance for a successful implantation and a pregnancy. So we
Yeah.
are using metformin in the context of improving your egg quality. So when you get an EMI report, if we see any red flag in terms of disrupted metabolic factor or hormonal changes that are more likely to impact your egg quality,
Yeah.
such as high testosterone,
Yeah.
high insulin,
Yes.
high
Hemoglobin
A1C,
A1C. Yeah.
exactly, high glucose level,
Yeah.
potentially PCOS,
Correct.
then we will recommend the use of metformin.
Excellent. And we do use metformin routinely in PCOS patients, some of whom have elevated hemoglobin A1C. For our listening audience, that's one of the parameters you look at to see if it's elevated, and may indicate whether someone is full blown diabetic or if
Hmm.
they're on the way to getting there. Although I usually say you probably want to keep an eye on it. You don't want your hemoglobin A1C even too high, because what is it? We say if it's 6.5 you're diabetic, it's 6.4 you're pre-diabetic. I don't know. That's not a whole lot of difference between 6.4 and 6.5. So it's probably better to
Yeah,
to monitor. So we do use metformin for that, and dietary recommendations that you guys make, right?
yeah, that's
One
correct.
of
Yeah.
the things, so you'd recommend metformin. Before we get to IVIG, I know we also talk about sometimes vitamin E or omega 3.
Yeah.
Um, if you include that in your report, what would you tell our patients, and where would they get those?
Yeah, so we are recommending a cocktail of antioxidants that will have exactly the same purpose of
Mm,
trying to minimize inflammation by suppressing free radical production,
mm,
which is a factor involved in oxidative stress that will also be negatively impacting your air quality. So we are providing you with some recommendation in that sense, trying to recommend the use of coenzyme Q10,
mm.
resveratrol,
Yes.
pycnogenol. We can also send link for you to buy on any platform like Amazon, for example. You can find
Right.
those online, very easy
Right.
to use.
Okay. Now, just a quick segue. I know you did mention antioxidants. Um, Several patients sometimes I don't use NMN that much. I like CoQ10, but some people do mention NMN. Do you guys reference that at all?
Not at all. No, no,
Not
no.
at
We
all.
are
Yeah.
really focusing on what we used to use quite broadly,
Right.
which is really CoQ10, resveratrol,
CoQ10.
and pycnogenol. Yeah.
Right. Yeah, I use CoQ10 as well. So, all right, now let's go into the IVIG. That's the big
Yeah.
one, because one of the patients that we have in common. Oh, by the way, she's now 22 weeks pregnant, doing well. Baby's fine, and I think you made the
Perfect.
recommendation to stop the IVIG. Her history was she had had 5 transfers, and out of the 5 she'd gotten pregnant 3 times. This was at the different clinic, and she always lost the pregnancy somewhere around 6 weeks, right? And they were like, we don't know what to do. So on her own she contacted me, and I said, well, let's explore this. Let's get some testing done with Pregmune. And so we did, and the recommendation came back to use IVIG.
Yeah.
Now, tell me, what would I see on that report that would say use IVIG?
So IVIG, just to give our listener a little background, that's
Yeah,
a cocktail of immunoglobulin. So that's a
yeah,
preparation done from donated blood plasma
yeah,
collected from thousands of donors. It's an infusion that you
yeah,
will have to get. It's a cocktail of immunoglobulin that you will have to get from drip infusion. So it will have to be given in clinical setting, either an infusion center or at home with a nurse.
mm,
So we are going to recommend IVIG for a few things that you can find on the EMI report.
right,
First thing will be really for a patient with a recurrent implantation failure.
Right.
the hallmark common for those patients is really a high inflammatory level with high
Matters. Yeah.
Th1 and Th2. We
Right.
will see a very high
Mm-hmm.
natural killer cytotoxic activity
Mm-hmm.
level, and we will see also the production of other cytokines that are detrimental, such as IL-17. So
Yeah.
if we see those parameters, IVIG may be recommended. It
Right.
can be also recommended for patients with recurrent pregnancy loss and more specifically secondary RPL, meaning the patient had already a live birth and then she experienced several loss with no really
No reason.
explanation. Yeah.
Yes.
And
Yes.
so in those patients, we are seeing very high concentration of
Mm-hmm.
antibody called HLA antibody. So
Right.
those antibody may
Mm-hmm.
target the embryo itself. And
Right.
when they are present in high concentration, they may trigger a cascade of
Right.
activation, complement cascade that will lead to the death of the
Right.
embryo and
Right.
so
Right.
a miscarriage.
Yeah. So just a quick summary. I know we talked about it in the first webinar. So Th1 are those inflammatory markers that are initially needed for an embryo to implant, but then they have to be suppressed. And then the Th2 that suggests immune tolerance has to come into play. And so when you have an elevated Th1 to Th2 ratio, say a 10.2 and 11.8 ratio, that puts the body in an imbalance where the
Correct. Yeah.
body attacks the baby, if you will, or the placental tissue, the growing placental tissue in the mother's womb is attacked, and that dislodges or attacked. So anyway, so we start IVIG, and it is immunoglobulin. So one of the things it is done by an infusion center, and they have to um, be pre-medicated before they get it. They get Solumedrol, they get some Benadryl so they don't get an allergic reaction to it. So now we give them IVIG. When do we start it? Right? How do we know it's working?
Yeah, so IVIG is usually started, 7 to 10 days prior to the transfer.
Yes.
Then at the time of the positive beta, so if you are
Right.
pregnant, you will have a second infusion, and after that,
Yes.
every 3 weeks through the first trimester.
Right.
So that's an infusion that has to be given every 3 weeks
Hmm.
through the first trimester, again in clinical setting with some pre-medication prior to
Right.
the infusion.
Right. So it's every 3 weeks, and then you monitor what? How do you monitor it?
So we monitor all the cytokine profile to make
Right.
sure that the inflammation that was
Mm.
really the reason why we, in the first place,
Right.
recommended IVIG is decreasing. So that's
Right.
one. If you were using IVIG because of high concentration of anti-HLA antibody, we
Right.
may monitor those as well
Those,
to
yeah.
make sure that they are decreasing or
Hmm.
staying at steady level.
Right.
So that's really depend on the reason why we recommended IVIG in the first place.
How often do you monitor it?
So if you are using our services with the AMI report, that will
Right.
be a monitoring every 2 weeks
Every two
from
weeks.
the pregnancy establishment up to 12
Uh-huh.
weeks.
Okay, up to 12 weeks of gestation. And
Correct. Yeah.
so do you stop it at 12 weeks, or what happens at 12 weeks?
Depending, we are screening up to 12 weeks. If at the 12-week mark we see things that are not quite optimal, we may recommend to push for another IVIG infusion. You can use IVIG through the pregnancy. Studies have been
Right.
shown that you have a safety
Right.
profile up to 36 weeks.
Uh-huh.
So you can use it through the pregnancy if needed. But for the sake of the AMI report, we are screening up
Hmm.
to 12 weeks. If at the 12-week mark, we still see spike in, let's say, a pro-inflammatory cytokine, we may
Hmm.
recommend another infusion.
Okay. So, just as a quick aside for our listening audience, it may not be covered by your insurance, right? It
That's correct.
just be
Yeah.
prepared for that. It may not be covered, and you would have to factor that into your finances because it can be a little expensive. So only if you need it. and be aware that don't expect your insurance to necessarily cover the charges from the infusion. Um,
That's correct. Yeah.
so,
The dosage is based on your weight, and
right,
we recommend to start with a low dosage of
okay,
200 milligram per kilogram, which will be roughly 10 gram per infusion
right,
if you are 60 kilogram,
person, right, right.
yeah, a
And
person.
then
Yeah.
you can adjust up or down.
Yeah, you can adjust
Mhm.
up and down depending on the immune profile. So again, if you are monitoring pro-inflammatory cytokine, if the decrease is not the one you would like to see, we can
Uh-huh.
increase the dosage.
All right. Is there a maximum dose?
With BRI, back in the day, we saw a woman with very, very high concentration of
Right,
specifically HLA-C
right.
antibody,
Uh-huh.
which is an antibody that is really is produced early on and
Right,
is the main cause of early loss. So for people having concentration of 10K, if not more, of those antibody, Dr. Braverman used to use 1 gram per kilogram a day. So that
right,
was almost 60 gram. Now we do see very good effect with roughly a dose of 200 milligram per kilogram.
right,
Again, we use the lower dose when we start. If a
right,
patient already used IVIG in the past and
right.
was unsuccessful, we may go to 400 milligram per kilogram, for example.
Excellent, excellent. So that's how IVIG is used, and I know we used this successfully in this patient who had previous repeated implantation failures as
Yeah,
well as repeated pregnancy losses when she managed to get pregnant. So she is pregnant right now. She's in her second trimester. We're very happy. Um, the the last thing I wanted to touch briefly, and I know you and I talked about this, and is tacrolimus, right? Right. So
yeah,
some people may ask me about, what is tacrolimus? When is it used? I think it was mainly from the literature from solid organ donation, transplant donation. That's where that data came from.
yeah.
And I asked you about it, and it's not one of the regimens that you guys recommend, but you had some reservations about it. What were your reservations?
Yeah, so tacrolimus is also known as Prograf, in case you have heard of that name.
Right,
So
right,
the issue with tacrolimus, so it
mhm,
has the same effect of prednisone, which is an
uh-huh,
immunosuppressant, so it will reduce inflammation.
mhm,
The issue with tacrolimus is that it can really increase your risk for diabetes by
ah,
threefold. So that's quite a lot, and we see a
right,
lot of patients with underlying issues such as PCOS or insulin resistance. So of course, we don't want to put them on tacrolimus. The monitoring of the drug is also a little tricky to make sure that the drug is beneficial to you and has an effect. We have to dose tacrolimus in the blood after
mhm,
starting it. And we have to make sure that the dose does not exceed 10 nanogram per ml to make sure it doesn't become toxic to you. So
right,
there is that to wait in. And
mhm,
of course, because the pregnancy will progress, hopefully,
mhm,
your blood volume will also increase and tacrolimus clearance might also change. So we have to adjust the dose as the
right.
pregnancy progresses. So it's not as straightforward, I would say, than
As
using
yeah,
prednisone. It
yeah,
requires a little more of fine tuning.
yeah. So that's not one of the ones that we do use, but like I said, I mentioned it for completion's sake, and
Yeah.
also to let people know that the facilities who are using it, it's more in a research setting, right? So if you're in a research setting and you're part of a clinical protocol that uses it, but it's not prime time what we would use every day, correct?
Yeah, just because there are drugs that are more easier to
Mhm.
use. Prednisone, again, it's an oral pill. Prograf, tacrolimus is an oral pill as well.
Mhm.
But because of that monitoring, that can be a little trickier.
Challenging, yes.
Yeah, and the risk for diabetes,
Right.
we are
We
not
don't
using it
we
as
don't use
broadly.
it.
Yeah.
Excellent. So tonight we talked about metformin. We touched a little bit about some of the supplements we would use, and we talked about IVIG, and we mentioned tacrolimus just for inclusion. So how would you sum up everything that we've said so far? I know that I have a lot of patients who are really interested in getting tested and to see um, what would benefit them, what would fit their particular protocol. So to summarize it, what would you say is number one, the IRMA report, the AMI report, and how we monitor these patients?
Yeah, so I would say with anything, you need to know for sure if you need it. Those drugs, as you mentioned, IVIG is quite costly. You
Yes.
need to pay the drug itself, but also the
Yeah.
service of the infusion center or the nurse. Of course, that's
Yes.
quite a lot through the first trimester.
Yeah.
So again, if you can afford, perfect, but it can be an issue. The money issue can be here. So of course, testing, that's really the baseline for anything. Being monitor, that will be step two, to make sure that everything is working as it should. And if there is any need in adjustment of dosage, we can provide that information to your physician with an AMI report.
Okay. Excellent. Thank you so much. I don't know if you have any additional comments. I think we have really tackled everything related to reproductive immunology. Um, just a quick pick. What is coming down the line in addition to what we're doing right now? What are you guys studying coming down the line what's in the pipeline?
Yeah, we have a few other reports that will be coming up hopefully this year. Some of the report that will try to analyze the reason of your implantation failure in an immunologic way, meaning immune testing post-transfer. As you know, the AMI report is done
Right.
only on pregnant patient progressing pregnancies, but
Right.
we have a few reports that will analyze the reason of your failure in an immunologic way. So that's
Mhm.
one. We are also working on trying to select an embryo based on his HLA-C content, to try to help you choose the right embryo based on your care. So that's
Excellent.
something we have done just a couple of times. We just starting. The patient had several loss. She was an
Right.
older patient. She had
Right.
quite 5 or 6 embryo banked, and she wanted to pick the best to try to optimize her chance. All were PGTA, so we are not going to touch the embryo itself. We are just going to get the alicot that was saved, the DNA alicot of those embryos that were saved during the PGTA test. So we are not going to defrost anything, just using those sample and try to see what is the best embryo that will trigger the least amount of immune spike to try to optimize your chance to get implantation and a successful pregnancy.
Excellent. Thank you so much.
Thank you.
I've really learned a lot from you, and this has been very informative, and especially for my patients. So, anyone who has questions, you keep me forward those questions directly to me, and I'll definitely pass it on. And if you want to know how you can get any immune testing from Pregmune, you can get referred by your doctor, or you can reach out to us, and we'll put in a referral form for you, and we always tell you the steps that are involved. It does take a few weeks to get the
The results
results.
back, yeah. Usually it's
Yes,
4 weeks for the
yes,
results to come in, and then
yeah,
an extra few days for us to put everything together and
yes.
provide you the report, yeah. So
Excellent.
5 weeks from the time of the blood draw, roughly.
Yes, yes. All right. Thank you so much. I appreciate it. Like I said, I it's always a wonderful talking to you, and I
Yeah, for
look
me
forward
too.
to our next webinar.
Thank you.
All righty. So.